It's my pleasure and honor this night to have Professor Tarek ElBaz. He's the great professor not in Egypt, but in the Arab world. And I like this photo very much. This is in the ESNT corner, when Professor Tarek ElBaz was the president of ESNT and started together to work in CME and education. I like this photo because it reflects the collaboration and the cooperation. And also, this is the last year photo of the SNT. And always I like this quotation. I have learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. This is what I always say, that Professor Tarek ElBaz is a very nice professor, always spreads positive energy for all colleagues, and I enjoyed working under his supervision and his direction to establish ESNT-CME, and I think all of us are proud, Professor ElBaz and me, by this achievement to have this collection of lectures and videos and degrees with the presence of great professors from everywhere. I think this is a great achievement, Professor ElBaz, and we are trying to do something, and we hope that we can go sky high to the highest level. Professor ElBaz enriched our ESNT-CME activities by more than 48 lectures, and the last one was metformin in the ESNT conference this year, and he has many videos, and this is 2 videos while he shared this session with Professor Robert Nejm early September, and this is the most recent presentation of Professor ElBaz about microbiome intervention in hemodialysis. This is during the activities of Nephrology a couple of weeks ago. I'm sure that this night will be very exciting because Professor ElBaz selected the diabetic kidney disease, and it is a very hot issue, and he will address challenges and new insight. I'm sure, as I'm expecting, it will be very fruitful for all of us. I'm going to stop here, allowing Professor ElBaz to share his slides. Please, Professor ElBaz. Okay, Professor ElBaz, go ahead.
Good evening, everybody. Professor Sheashaa, always great to see you. You always are so kind and you say so much about me, and you have achieved a lot by all the hard work. Many years back when I started my career, I was very much interested in diabetic kidney disease. At that time, it was diabetic nephropathy. And I thought, and everybody thought, it was the end of the end of the pathology and the end of the story, 5 stages, and they progressed to reach end stage in some of the patients. And it has been so confusing and very difficult to really find the cause for diabetic nephropathy. Then more and more insights and new advances kept on coming. And let me share with you what I have to say today and start by the challenges. Still, sadly to say, diabetic kidney disease is still the leading cause of end-stage kidney disease. The progression is terrible. It affects the treatment of the disease. Not only this, if we realize how many patients are on dialysis now worldwide, 3 million. And you have to realize something very sad, which is the fact that there are 9 million deprived of dialysis in emerging nations who do not have this type of facility. Makes us even more sad. Well, diabetes affects 415 and maybe 450 millions worldwide today. And nephrologists like us, if they are sitting here talking about diabetes in 25 years, I don't think I'll be around, or I'll be a very old man. I won't be able to talk about diabetes. We're going to have 700 million diabetics. Can you imagine 700 million diabetics? That's the real epidemic, not the COVID. The COVID will find a solution within a year, 2 or 3 or 4. 4 million that have died so far of COVID are nothing to compare to what these diabetics are spending and causing sadness and morbidity all over the world. A decade ago, the occurrence of chronic kidney disease, or let me say the incidence, had dropped due to better adoption of therapeutic strategies. Yet, later on, it started to rise again between 2013 and 2016, and this was the fact due to the increase in the number of diabetics, generally speaking. We are aware and quite aware that albuminuria no more is necessarily associated with diabetic kidney disease. You may have a subset of patients who are non-proteinuric, as you can see depicted in the slide. So this point has to be borne in our mind when we are treating our patients, and I'll tell you why. I came across this recent publication just today, so I wanted to share it with you because I find it's very consistent and very important. It came from Japan, and it's a nationwide biopsy-based cohort study over the last 30 years. It was a retrospective analysis. They looked into, with very specific design for the trial, into all the biopsies that diabetics had over the last 30 years, and they used the Fiorito classification in order to define the changes, pathological changes. They found that the predictors present in the biopsies for the occurrence of the CKD progression in the non-proteinuric type were a low hemoglobin, patients that were using EPO, and a severity of EFTA. Imagine EFTA in diabetic kidney disease, yeah, just like the one in transplantation, interstitial fibrosis tubular atrophy. Well, this point is not new, but the 5-year survival or the 5-year CKD progression-free survival was much higher than the proteinuric form, 86.9% with a confidence interval of 95, while the proteinuric patients had the 24.5%, meaning that patients who are proteinuric would progress to end stage or later stages of CKD much more faster and even more than patients who are non-proteinuric. No one can really answer the question how many patients, what is the percentage of the non-proteinuric forms of diabetic kidney disease versus the classic diabetic nephropathy. Some say about a third. Is not sure because this is biopsy-based statements, and we understand that biopsy has a very strict indications, as Professor Sheashaa showed us last week on one of his tubes, and he had discussed the indications for biopsy. So the identification of the high risk is something very important, and it's totally understood. Not all diabetic kidney disease patients are going to progress like each other, and hence we really need new biomarkers in order to help us define these type of progressors, particularly those who do not have microalbuminuria passing into macroalbuminuria and so forth. This is rather difficult type of patient, so we need biomarkers, and listed here in this slide, maybe this could be of help in this recent publication by Shen and his workers. You can see they were using the KIM and the tumor necrosis factor receptor 1 and 2 as a biomarker. Also, we have to realize that NGAL is very important biomarker to detect the early pathological changes, particularly in the early stages. And since the disease affects now the proximal part of the nephron, it is completely logical to realize how NGAL could be of help. Of course, if you have a histopathology for any indication, it would be quite helpful to see the changes in the early stages or the later stages that would show you tubular basement membrane thickening and interstitial changes which are dominant together with the arteriolopathy, I mean the hyalinosis. Now another challenge, and what we already know, that type 2 diabetic patients, if they acquire the disease early in life, meaning less than 40 years of age, they have a higher risk of diabetes-related complications. And this is a fact. And this question was asked towards researchers in the field of diabetic kidney disease. Is this valid as well for diabetic kidney disease? Zheng from China and his workers did this very good work. They worked on 1,100 type 2 diabetic patients who were younger than 40 years, and they had a higher body mass index, and the lipid profile was bad. Also, the blood pressure was most of the time out of control. I mean, the associated factors or comorbidity, let me say, was there. And the results of this interesting work showed that the early onset group had a twofold higher expectancy of the occurrence of end-stage renal disease than the ones that acquired diabetes later on in life. So the earlier a person acquires diabetes and the worse course that he runs, means that he is susceptible not only to all types of complications, but to diabetic kidney disease in particular. Maybe most of you would remember Professor Agrawal. About 3 weeks ago, Professor Sheashaa invited him to a webinar, and sadly, he mentioned that around the world there's 850 million people with CKD. Those the ones I'm talking about in relation to dialysis, and they are costing the United States a rather terrific number of dollars, 114, yet it seems it's still not enough when you look at this slide of his, showing you that research-wise, for HIV in the United States, each patient would cost the government $2.5 thousand, while the poor kidney patient receives only $15 per patient in regarding to research. So where is the proper fund? Why I'm so interested in what the United States is doing and saying? Well, this is naturally, this is the country that is leading in research, not only in the field of medicine, but in all sciences. And it is important for us to realize this problem. Not all the emerging countries have the facilities for this high caliber research that the US is doing. So what they are doing, also they have another kind of, let me say, challenge. Nephrologists are leaving the specialty. They're not getting enough paid. Someone who is working in intensive care or transplantation is getting paid just like someone working in a general ward or a general ward or a nephrology ward. So they are starting to scream, and their voices is reaching the stakeholders and the government now. They started to change the nomenclature from end-stage renal disease to end-stage kidney disease to make the language easier for everybody to understand, just like the changes that happened for acute kidney injury instead of acute renal failure, and chronic kidney disease, and so forth. Not only this, they have also made subspecialties dedicated, as you can see, listed in this slide, in various fields of nephrology. In Egypt, in our Egyptian society already, we have chapters dealing with all of these different specialties since 15 years. But we still, these specialties are really not well evolved or developed when it comes to practice, except for transplantation. Those who are working transplantation are there, but otherwise the nephrologists will be doing everything at the same time. The first insight I want to talk to you about tonight is pathology. And this is a rather new point, and it will come at the end of the talk to focus again. As I mentioned, the type 2 diabetics are non-proteinuric. The problem starts at the proximal tubules. And here what is happening that the advanced glycation end product receptors and its ligand, the AGEs, bind together, and under the effect of a lot of reactive oxygen species with this glycemia that is occurring, there is disturbance of autophagy and lysozymes, and this is very important step before the appearance of any glomerular diabetic changes. So it seems, according to this new insight in pathology, this is a very important initial point of damage in the kidney due to hyperglycemia and the oxidative stress that's going on in relation to the hyperglycemia. The wonderful hypoglycemic drugs we have in our armamentarium now are plenty, and they give us no excuse not to tightly control the blood sugar of our patients. I'm just undermining or highlighting the most important ones in my view in regards to benefits beyond the glycemic control. I'm sure you are all aware of these drugs within the boxes. So saving the kidneys from diabetes would need precision from the treating physician and individualization of therapy, bearing in mind the associated morbidities that certain drugs should not be used and other drugs should be used as you gather. Looking at this recent publication from Kidney International, you find it's not important at all. Maybe it is harmful to try to be a hero and reach a glycated hemoglobin of less than 6.5% in a patient who has a severe CKD, or he has lost his hypoglycemic awareness, or his life expectancy is too short, or there are serious comorbidities such as advanced heart failure with depressed ejection fraction, or macrovascular complications. All these type of morbidities mean that you have to be a little bit, let me say, a little bit flexible or a little bit lax and free to keep the glycated hemoglobin below 8, because if you try to achieve the targets of the guidelines, you may do damage to the patient, as hypoglycemia could be really serious. Always when you treat your diabetic patients, have a big, wide bird's eye view, seeing everything, seeing all these factors together, and approach them holistically, because if you're not going to treat the hypertension or lower the lipids and so forth, like all these circles point to, then you are in trouble. I mean, the patient is going to be in trouble. So the holistic approach is something very important. Until recently, we nephrologists were not talking about SGLT2 inhibitors or DPP4 inhibitors or even the GLP-1 receptor agonists, and they were just pronounced by the diabetologist and drugs to treat diabetes, until it proved the recent trials that these new oral therapies have proven benefits that beyond the glycemic control, as I earlier said, delaying the progression of CKD, helping in losing weight, helping in reducing the blood pressure, and as some of the trials showed us for the SGLT2 inhibitors, there's a lot of cardiovascular protection. We are aware last year of the publication of the Credence and the Light trials. The Credence did show that there was very good results in altering the sequence of chronic kidney disease. They were working on patients with high urinary albumin secretion of around 1 gram, and the GFR was around 56 ml per minute. And the results showed a reduction of 30% after a follow-up of 2.62 years, related to the sustained doubling of the serum creatinine or death or the occurrence of end stage. Well, this year, of course, you are aware of the DAPA-CKD, and this percentage rose to 39, which is a very excellent result. The DELIGHT study further added that for patients that were receiving dapagliflozin, it was much more beneficial regarding reduction of albuminuria if the DPP-4 saxagliptin is added. We don't have saxagliptin in Egypt, but this is the results according to the DELIGHT. Naturally, you are all aware of the DAPA-CKD, so I'm not going to talk much about it, but it has resulted in putting dapagliflozin in a very high position, and I think now is sitting next to the ACEs and ARBs in the same front row as an important drug in nephrology and for cardiologists as well, not to mention diabetes. I think it's better in treating chronic kidney disease, and it will be more beneficial than in treating diabetes. The renal outcomes of the SGLT2 inhibitors, I'm sure you are all aware of, and the benefits gained from using these drugs, and lately also the glucagon-like peptide 1 agonists. And you can see this slide showing the different forms of the GLP-1 agonist, and I'm just pointing to dulaglutide and semaglutide. You have the dulaglutide here in Egypt, injectable form, and you can use both of these extended use, extended release GLP-1 agonists without fearing much when the GFR drops. Why is this important for a patient with chronic kidney disease? Because now GLP-1 are in focus, and a few recent trials, and there are ongoing trials now calling us to have more interest in the GLP-1 because they have some indirect and direct effects that are not only beneficial to the kidneys, but also to the heart. Maybe you like to have a closer look. I will try to expand here. You can see the indirect effects related to improved glycemic control, weight loss, improved blood pressure control, improved left ventricular wall motion, and so forth. And on the other hand, you can see the direct effects related to the renal endothelial dependent vasodilatation, improving the GFR, the modulation of the sodium and water homeostasis with its effects on the blood pressure, of course, and so forth. So it seems that the GLP-1, again, will be in focus, and we wait for the ongoing trials to tell us more about it. Everyone is interested to hear about bariatric surgery. We were maybe not that aware of bariatric surgery. The results were very discouraging when it started more than 2 decades ago. Well, now bariatric surgery could be regarded as a treatment not only for obesity and hypertension, but also for CKD, and particularly those patients with type 2 diabetics. It is a quite an effective therapy for obesity, hypertension, but you have to carefully select the patient, and the surgeon should be aware of all the challenges in order to get the best results. Obesity is serious, and as you can see written at the bottom of the slide, it's causing around 4 million deaths a year due to the associated comorbidities. I put this wonderful sculpture by a sculptor from Mexico. He's quite famous. His name is Victor Hugo Penna. He is famous for his sculptures in wax, and this particular figure, he made it under the theme of a man can change himself. It's got nothing to do with obesity as a matter of fact, but this is the theme, a man can change himself, and I thought it is very suitable for this particular slide from this sculpture by Victor Hugo Penna from Mexico. This is the type of surgery preferred, the Roux-en-Y, and surgeons are not advised to do the vertical sleeve. This is the preferred type of surgery, and the renal protection happens due to the bariatric effect or the metabolic effect or the anti-hypertensive tensive effect related to removing all of this fat. And for bariatric effect, it's very interesting to realize that all the bulk of perinephric fat, when removed, will decrease the intrarenal vascular pressure, which enhance and improve the GFR, which has been declining. And maybe the metabolic effects due to various points, as you can see here, the increased preferential insulin sensitivity, incretin effect, and even the reduced hepatic glucose production. All of these are helpful. Together with controlling the blood pressure, we understand so well, I mean, that controlling the blood pressure has a wonderful renal protective effect. Now, moving on to the novel therapeutic trials, and this is a very recent publication. I'm not going to go through all of these trials, of course, but just to say a few words. Not all of the drugs that have been tested have proved to be effective or safe. And let me say, generally speaking now, that the antifibrotics are not favorable anymore due to a lot of side effects related to the cardiovascular system and related to water retention and maybe the occurrence of anemia with some. So the most favorable drugs are gaining now a lot of interest. Besides the SGLT2 inhibitors are the anti-inflammatory, not the anti-fibrotic anymore, or the paricalcitol, which was effective, yes, but was associated with marked depression of the PTH, and we don't want this to happen. Also, a drug like the allopurinol did show some good benefits, but we all understand that allopurinol is not without adverse events, particularly in patients with depressed GFR. This is more and more of the trials that have been done or ongoing, and I'm just going to check or focus a little bit on a few of these drugs later on the coming slides. I put this slide because I found this very interesting and easy to show you how the different drugs would work. Maybe you would like to use drugs attacking the inflammation. We understand that type 2 diabetes or diabetic kidney disease results in an inflammatory process. And this group of drugs, whether the anti-chemokines or the anti-TGF alpha, not in use anymore, of course, or the pentoxifenolin, these are working at the site of inflammation. Or you would like to fight the oxidative stress and use xanthine oxidase inhibitor, which again, as I said and mentioned, that it is could be helpful, particularly if a patient has to take it, but once the GFR has really dropped to below 45, I wouldn't advise using it. As for the last channel is related to vasculation, and already we are using the SGLT2 inhibitors, and GLP-1 agonists are coming in focus as well. So this is again a very attractive site for future experimental therapies for diabetic kidney disease. I want to share with you the results of the SONAR trial, which was published early last year. They tested the atrasentan, which is an endothelin-1 receptor agonist. Of course, atrasentan was quite effective in decreasing the albuminuria and the progression of GFR. No one could deny this, particularly this molecule, which was much better than its two predecessors. Yet, just early this year, in last January, another publication came in the Lancet, mentioning that those patients that received the atrasentan had a great problem of increased hospitalization due to the heart failure, and this is understood due to the fluid retention for patients who are using the atrasentan. Another difficulty when using this particular drug is you need to be very critical about using diuretics, and we all use diuretics with our patients and know how difficult it is. Sometimes it is rather impossible to keep track of your patient, and you want to see what's happening, what type of complications he may be facing. is the diuretics effective or not effective? So this is an added difficulty to using atrasentan. Yes, it is effective if you can individualize its use in a particular patient who's not going to, you're not going to worry about too much fluid. Pentoxifenolin stood the test of time, and since 1982, diabetologists and physicians generally have been using it to treat intermittent claudications in diabetics and peripheral vascular diseases. So there is nothing bad to say about its safety. It is quite safe. And a lot of evidence showed that this old drug and relatively cheap drug is very important in the context of being anti-inflammatory, which is something very important now, and all the future experiments, most of them would be directed in this particular channel. Not only this, pentoxifenolin in a trial or two has been used together on a background of RAS blockade and showed added benefit. And another point that may interest you, if you are going to use pentoxifenolin for your diabetic patient, you may be happy to know that you can use it in a patient when it is time to stop the RAS blockade, when his serum creatinine is high, 4.5. You can't give him RAS blockers anymore. Still, you can use pentoxifenolin and get more or less good benefits related to retarding the progression of the disease. The last trial I want to show you today is a very recent trial, the Fidelio DKD, and notice it is the DKD trial and not CKD. This trial has been directed specifically to diabetic kidney disease, and the authors or the researchers of this trial have tested the third or the newcomer of its kind, mineralocorticoid receptor antagonist called finerenone. And finerenone is supposed to be much more potent than eplerenone or spironolactone, and does not have this very bad side effect related to hyperkalemia. The results so far are in a press release, and they seem to be very encouraging, The results will be published soon in a mega event, not announced yet, but at least the press release says the Fidelio DKD trial showed benefits of the finerenone in decreasing the occurrence of kidney failure and in the doubling of the serum creatinine patients. The last thing I want to talk to you about in relation to novel therapeutics is this new approach, very exciting. Of course, there are many. I just picked this one because it seems to be something very exciting and surely is paving the way to the future in therapies or novel therapies. I hope these type of drugs used to block the connexin 43 mediated hemi-channel activity. What does this mean? The final statement is blocking this connexin is very important in maintaining the integrity of the adhesion molecules between the tubular cells. And as you recall earlier, I did show you this slide related to the ages and rages combination under the effect of ROS. And this is what is in the depth. This is what's happening. What's happening is disruption of the adhesion molecules between the cells. And this is, let me say, a very primary step before the occurrence of fibrosis, which is the resultant point, the tubular tissue fibrosis, which is underlying the pathology now of chronic kidney disease. This is my final point I'm addressing. I'm not going to talk to you about the guidelines. I'm sure you are all very happy as much as I am. Professor Hussein Sheashaa last week in his YouTube did a wonderful summarization of the guidelines. You can see here how the RAS blockers, how the SG2 inhibitors are sitting closely to the RAS blockers, and that most patients would be receiving them. This 200, almost 200 pages guidelines is for you to read well and digest. I cannot say much about it. It is very interesting. And again, looking at one of the beautiful diagrams they put, I think it's one of the most illustrative and easily to comprehend guidelines ever done by the KDIGO. I don't know. I like it so much. You can see here that the metformin and the SGLT2 inhibitors, again, are regarded now as first-line therapy, because last week someone was talking about metformin in a way I didn't like so much. Well, they want to push it out, but please keep it, because we know the benefits of metformin related to many, many things, particularly nephrology. So in conclusion, ladies and gentlemen, I hope I didn't take such a long time. The prevalence of type 2 diabetes and CKD sadly still increasing. We still are searching for biomarkers next to NGAL and the others. The available drugs allow us a better chance for individualization of therapy and leave us no chance not to treat our patients in the proper way. And these new medications, as the studies showed us, are safe and have benefits beyond glycemic control. And the good news again is combining the SGLT2 inhibitors with the RAS is now a standard of care in diabetic kidney disease. And definitely our new guidelines are going to be very helpful for us in treating our patients. Thank you all for your kind attention. And thanks once more, Professor Hussein, for giving me this one.
Thank you very much, Professor ElBaz, for this very nice presentation that carried a lot of challenges and a lot of the future aspects of the diabetic kidney disease management. I like all the studies you mentioned, either for the future, and I'm happy by the results of finerenone, because as you mentioned, this is the new generation of mineralocorticoid receptor antagonists, devoid of all the side effects of spironolactone. There is no gynecomastia. Even hyperkalemia is less frequent with the use of this new generation of mineralocorticoid receptor antagonists. So I'm happy by the positive results, interim results of the finerenone trial in diabetic kidney disease.
We'll see, it's going to be published soon. It's just a press release, but rather encouraging as.
Yes. So this is a second point regarding saxagliptin. I don't like it because saxagliptin is famous by cardiac problems and hospitalization with heart failure. So this is why we don't like it as DB4 inhibitors. Lastly, to leave the room for discussion, pentoxifillin. It's a very cheap drug, and it seems its pharmacology is fantastic, and it can be used with advanced stages of CKD, even if estimated GFR is less than 15 milliliter per minute. So I like to leave the room for the professors and the colleagues to start to share in the discussion. Okay, Professor Faissal Shaheen. You are unmuted, Dr. Faissal.
Prof. Tarek, excellent talk.
Thank you, sir.
Okay. Is it okay?
It's okay. It's okay.
Yeah.
Yes, I hear you well.
I like the talk very much. It's very systematic and it goes to the target. I wonder, probably you have the same experience. We have so many patients after bariatric surgery, they develop kidney stone and even gallbladder stone. So this is one of the things maybe is the back, with geriatric surgery, less of water, and probably they will harm the kidney as well. You brought the other side, which benefit in diabetes, which is, I agree, but still we have a problem with the stone formations on such patient, isn't it?
And hypovitaminosis, of course, is another, and the iron deficiency anemia. There's a lot of complications related to this surgery, as a matter of fact.
So I think for bariatric surgery, Professor Shaheen, is to prepare the patient well, not to be very late, and I think laparoscopic or endoscopic partial without resection anastomosis, I think it is with less side effects. So I like this way rather than doing bypass surgery, because bypass surgery is associated with many malabsorption syndromes that can lead to increased oxalate and oxalate deposition and oxalate stone formations. So so this is why we prefer the endoscopic rather than diversion surgery.
So you prefer sleeve operations,
Yes.
not bypass?
Yes.
Okay.
Yes.
But according to this publication that I showed you, it was advocated to use the Rowan Y, not the horizontal form, the sleeve, in this particular regard. Or this is what the authors mentioned. I don't know about sleeve. I'm not too much into bariatric surgery and the outcomes, so I can't really argue a lot about it.
I think the topic of bariatric surgery for treating hypertension and diabetes is very appealing and exciting. And we may prepare a session for the pro and cons and critical appraisal of bariatric surgery, because there are many data registry from UK, US, and others for very large number of patients for whom bariatric surgery was conducted. So I hope in the near future to cover this topic well. But currently I am advocator for bariatric surgery for patients with morbid obesity and comorbidities like diabetes and hypertension, because it makes a great difference. Okay. Dr. Faissal?
I'm okay.
Okay.
I'm okay.
Thank you very much. Professor Riyad Said? Please unmute yourself, Dr. Riyad. Mr. Noor.
Dr. Tarek, it was a nice talk, to the point, comprehensive. I have just a couple of points I'd like to ask. You did not really mention anything about the role of kidney biopsies in dealing with a patient with diabetes, when to do, when not to do, and what will be the outcome. Because we do see a good number of non-diabetic renal diseases nowadays in diabetic patients. You'd like to elaborate on this, please?
Yeah, I didn't address this particular point because I thought that the majority of the audience would know when to biopsy a diabetic patient. We as nephrologists, we don't like to go on and biopsy diabetic patients just for the sake of research. As some of those biopsies, as a matter of fact, that I showed you, done in Japan over 30 years, some of them were done in this regard. Yet there are certain indications to biopsy a diabetic patient. So if you have a particular patient with sudden worsening of his renal functions, not explained by any degree of CKD, this would be an indication. The appearance of hematuria out of the blue. Why should a diabetic patient have hematuria? This calls your attention that maybe there is an active urinary sediment related to an active glomerular lesion. Sure, as you said and you mentioned, Professor Riyad, there could be associated diseases affecting diabetics, and multiple publications were done in this regard. I myself, many years ago, I did biopsies for patients having bilharzia antibodies and did find some very interesting lesions in our group of patients who were micro-albuminuric. Also, the association of other diseases, if you have any kind of manifestations to suggest a systemic disease, a very high sedimentation rate, marked normocytic non-multiformic anemia. I mean, any kind of symptomatology or lab results that would point towards an autoimmune disease, for example, you would expect worsening of the renal functions or the appearance of proteinuria when there wasn't any. This could be an indication for the biopsy. The precautions that you would take are the precautions that you would take generally for any patient who are submitted do a biopsy, and we always like the biopsies to be made under direct imaging to achieve the best results.
I think
you.
Professor Riyad Said had a very nice experience, and he presented this nice experience during the Luxor meeting a couple of years ago about the non-diabetic pathology in diabetic patient. So to put in mind if there is any clinical stigmata toward a certain etiology, to do biopsy for the patient. But I agree with Professor ElBaz that we don't do biopsy for research purposes only, because we ask ourselves what is the value of the biopsy. Should we manipulate? Should we modify our treatment based on the pathology? If the answer is no, I think for practical reasons, biopsy is declined. I think this is the issue.
I agree 100% with Dr. Tarek, what he mentioned about this, just to stress the point that still there is a role for a kidney biopsy if it is indicated, not really to say everything that this is diabetic nephropathy. Diabetic nephropathy is a pathological diagnosis based on findings. Now, diabetic kidney disease is different, as Dr. Tarek really elaborated. Now, I'd like to have another question to dear Tarek. Now, I know that you are a fan of metformin, and I'm self also, and also nowadays with the SGLT2 inhibitors. Now, what's your really cutoff point when to stop using metformin and SGLT inhibitors in a patient with advanced renal disease?
You know, for the SGLT2 inhibitors, when they first appeared, they were telling us not to use them below a GFR of 45. And the DAPA-CKD, as you all are aware and yourself, that they were working with patients with a GFR much lower than that, up to 35 as far as I remember. So this could be a cutoff for using the SGLT2 inhibitors. Also for metformin, I would use metformin for patients with a full dose before the GFR drops to 60, and from 60 to 45, I would halve the dose. And below, did I say 45 to 30? I'm sorry, 45 to 30. And below 30, I would be a little bit worried to use metformin, except if I have a very close observation of my patient, let me say, and he doesn't have those type of comorbidities that would imply that he has a higher chance to develop a diabetic ketosis. Mind you, this drug, I'm sure yourself as much as others have seen the least of this lactic acidosis complication. But naturally, if you are giving this drug to a patient who has an advanced heart failure and his body is so wet and he has an infection, well, this is inviting lactic acidosis without metformin, by the way. But generally speaking, to the general practitioners and whoever is using this drug without the capacity to see his patient frequently, it's advised, according to the guidelines, to stop it once the serum creatinine is around 1.4, as far as I remember, or I use the GFR better, let's say until 40 to be on the safe side.
Okay.
If we go back to the pathology, we learned it from the Japanese and others, that the pathology is there. Even there is term silent nephropathy in diabetic patients. This means that the patient has no albuminuria, kidney function regarding serum creatinine and GFR are perfect, and the patient still has pathology, has the diabetic kidney disease pathology. This urges us to increase the dealing with lifestyle modification and to increase the awareness of the community toward the proper health, the proper diet, and everything to prevent diabetes. I think the radical management of diabetic nephropathy is to prevent diabetes as we can.
Our friend Hisham Sayed yesterday was giving a wonderful talk about the future of dialysis.
Yes.
So sophisticated, very expensive. And then I realized those poor 9 millions all over the world who do not have dialysis, and someone else is talking about the implantable and the wearable and, and all the sophistication and what you'll do in the dialysis unit for COVID, please. And we're going to have 700 million diabetics in 25 years, and we'll be still talking about diabetes. This is the epidemic. This is what you are saying. We have to be more preventive. Why did the president of the ISN a few years back, if you remember, said 0 AKI by 25? You all remember this, of course. I don't know where 0.25 by 25 is right now in Africa, but this was a very good insight and a good vision, particularly for someone who is a strategy maker for an international society. So just what you said, to be preventive and to help those diabetics. Of course, the AGL2 inhibitors are wonderful drugs, but mind you, they are still very expensive. You can't give them to all patients in my country. Right, Hussein?
Right, very right. So I remember one of the advices of Dr. Tarek Tantawi, and he's with this meeting, is to do campaign to combat obesity everywhere, in young, in middle age, because this is a gate for diabetes. If we succeed,
sure.
If we succeed to reduce the rate from 10 to 5, this is a great achievement. Even if it will not be 0, I think it is a real advantage. Dr. Tarek, Dr. Tarek Tantawi, do you like to add any point here? So I think it is now done. Dr. Said Khamis, do you have any questions to end this session by Dr. Said?
Yes. You got all my friends tonight. So nice. So nice.
Good evening.
Good evening, Dr. Said.
Good evening, Dr. Hussein, Dr. Tarek, Dr. Riyad, Dr. Faissal, all my colleagues, and Dr. Tarek. Actually, it was a brilliant talk as usual, Dr. Tarek, really.
Thank you.
Really, I have no major, just in a funny way, I'd like to say in Arabic that this is the night of the sugar or sukkar, and the next decision will be the night of the malh, ablah, inshallah, Dr. Second thing is my question to Professor Tarek, the relation between hypertension and diabetes. In a lay people way or talking, we know that diabetes can lead to hypertension from the natural history. But what about the hypertension? It can lead to diabetes. That's my question. And thank you so much.
Thank you very much, Professor Said. This is a very straightforward question, and I think I can have a straightforward answer. No, I'm not aware that hypertension can lead to diabetes, except if they are together within the metabolic syndrome. This lipidemia, as you know, may, particularly if you start treating with statins, particularly rosuvastatin, you may have patients that have worsened diabetes or develop diabetes. But mind you, this type of patient has to be genetically predetermined to develop type 2 diabetes. But hypertension causing diabetes, unfortunately, I have not come across any publication in this regard. Maybe the other professors have an insight. وانت عارف حاجه ومش راضي تقول لي انت شرير.
He is شرير, yes.
Yes, he is شرير. That's good.
Okay. If any one of my dear colleagues and professors want to add anything, I'll be happy. If not, let us go to the closing of this session. It is very bright, illuminating, and a lot of issues regarding the future management of diabetes, inflammatory, and other cascades, and the current and real management advances. And I like your way just to refer to the guidelines instead of reading guidelines. And I would like to add only one statement for the guidelines. It's very beautiful, full of practice point. This is what I like in the current guidelines of KDIGO for management of diabetes and chronic kidney disease. Adding practice point, and the real challenge is combining metformin plus SGLT2 inhibitors when GFR allows, and this is the current management of diabetes. It may be an expensive modality, yes, but it adds a lot. It is protective for the heart, for cardiovascular system, reducing obesity and body weight. And I think this expansion, we should think of it until we have other studies in epigenetic inflammation. Really, I enjoyed your presentation very much, Professor ElBaz, as usual. We learned a lot from your presence and from the data you mentioned. And this is just a symbol of appreciation. And this is just to
that's so
say,
kind of you.
No, to say thank you very much. And again, before saying goodbye, the Academy of Kidney Disease and Transplantation belong to ESNT-CME. The Professor ElBaz was the man who started this journey, and I think we are going forward for more and more refinement and progress in this field. But the man who initiated the task and initiated this mission was Professor ElBaz. So I'm always...
It's a dream you made come true, Hussein. Thank you so much.
I am always appreciating your efforts, and thank you very much for this night. Hoping to have you with us again and again. Thank you and goodbye.
Thank you very much. Good night, everybody.
Thank you very much.